2-year-old male to the ED after an automobile collision in which he was an unrestrained passenger ejected from the vehicle. Did we already do this one? I thought we already did this one. Maybe not. All right. He has obvious facial trauma, multiple broken facial bones, blood and debris in the airway, cyanotic, shallow respirations, and does not respond. Has significant bruising along his mastoids and under his eyes. Demonstrates a palpable femoral arterial pulse. And which of the following is the most appropriate next step in managing this patient?
That's not how good you are.
It's true.
You're not a piece of shit, you should do me.
I think they want to do CPR.
Yeah.
Yeah, probably. There's all that.
Yeah, you got significant facial trauma. So broken facial bones. And then what else? So yeah, we have the broken facial bones. What else on there is concerning? Yep, cyanotic. What else? What are the bruising and the mastoids and eyes? Like basilar skull fracture signs. Yeah. So what are we thinking on this? Right. Yes. C. Perform emergent right. Good. What if he's going to surgery? You got to decompress the belly. Would you do an NG too?
You do an OG.
Yeah, you could try an OG. Yep, if you can with all that facial trauma. But yeah, you want to avoid like an NG too. Good. Let's do another one. All right. Ambulance arrives with 29-year-old male. Crashed his truck in another vehicle. Vital signs: 80/52. Heart rate 136. Rest was 10. 98.2 temp. SpO2 98% on 15 liter. Primary survey is unremarkable except for some bruising in the lower abdomen. He's got a seatbelt sign, diffuse abdominal pain, EMS administered a liter of crystalloid fluids en route to the ED. EFAST is negative. Which is probably the most appropriate management for this patient? What are we doing? Yeah, A, right? We need to get some blood, and then he needs to get his abdomen opened up. So he needs an exploratory laparotomy to figure out where that bleeding is coming from. And I think we got one more. All right, you got a 60-year-old male brought into the rural ED after a rollover. EMS intubated him using a 7.5 ET tube, verified direct visualization and end tidal capnography. They have obtained IV access. Report the following vital signs: blood pressure 100/70, heart rate 90, rest was 18, 100% SpO2 with a BVM on 10 liters. Patient is transferred to the bed in the trauma bay, and you begin your primary survey. You note decreased breath sounds on the left without evidence of JVD or tricular deviation. ET tube depth is 28. What is the next most appropriate step managing this patient? Should we stick a needle in his chest? Maybe, yes, no. What do we think? Which one? Shoot, I think I heard that. I heard like A, B, D, E. Yeah, so this one, I mean, it sounds like to me, and obviously, I mean, I don't think I wrote the question, but somebody did, and I've reviewed it many times. So this sounds like a right main stem bronchus intubation. So we want to, deflate that ET tube and pull it back. Typically, in most adults, 23 at the teeth is a common, the common depths. There's some like math formulas you can use. It's usually like ET2 times 3 is usually the depth, but typically most adults, 23 at the teeth is a common depth we can use. All right, let's move into this lecture. Hey, there's our reference, good old Tin Alley. And this is what we're going to talk about today. Same thing as always. Some pathophys, some epidemiology, what we do, pre-hospital, hospital treatment, complications, disposition, all that fun stuff. Here's our warm-up case. So Got a 45-year-old unbelted male driver involved in front end MVC. Paramedics found him disoriented, not responsive to commands. GCS was 11. However, he deteriorates during transport and arrived with a GCS of 10. Vital signs are otherwise stable. No apparent trauma outside of a deformity to the left upper arm. Initial exam showed a contusion on the scalp as well as a palpable depression along the right temporal region. Pupils are both equal, responsive bilaterally. Initial fast is negative. And what are the priorities for this patient? So there's obviously some sort of head injury, but we manage these the same as we do everybody else, all trauma. So it's, X, A, B, C, D, E, F, G, elemental P, all that fun stuff. I don't think it goes up to that many, but we keep adding stuff to it. All right, so there's, we perform our primary survey just like we do everybody else. And we'll talk about what's important for head injuries. There's a couple things we like to do differently to prevent like that increase in intracranial pressure, and that could subsequently lead to herniation. So we do things a little differently, and some of them are simple maneuvers, but our goal is to you and normal everything. So normotensive, we want no hypoxia, everything normal, euglycemia, and we'll talk about why here as we go through. But we have our, we classify traumatic brain injury based on typically their GCS score, and we kind of classify the severity. You'll see some, these classifications may be a little different. The only thing you'll see different sometimes, certain classifications say mild is a 14 to 15 GCS. Some say it's a 13 to 15 GCS, or something to be aware of. I won't get super technical about that on a test. But you have, mild, which is going to be your most common, followed by moderate, and then severe. And we base it on that GCS score. So, 13 to 15 mild, 9 to 12 moderate, and then severe is going to be anything 8 or below. And if we remember, it doesn't go to 0. Although you may hear some people sometimes accidentally yell like 2 when we're doing our GCS in the trauma room and everybody stares at them. It happens. We all make mistakes. All right. So the issue with the brain is we got, we have all of our contents in the skull, which, doesn't expand or contract or anything. So any like dysregulation in any of those components or anything traumatic, we have our 3 components in there, which are our brain, our blood, and then our CSF. So if any of those change, another one's going to either increase or decrease, but we can't, it really can't manage the pressure once we have some sort of insult to it, and that's where we run into problems with herniation and other pathology that we're going to talk about today and worry about in the brain with the bleeding. So something has to change in there, and one of those things that changes if you got a bunch of extra blood in there because of a bleed, you're then going to have an increase in your intracranial pressure, which can, subsequently lead to like a decrease in that central perfusion pressure, leading to, all sorts of other complications. But mainly our, one of our biggest concerns is going to be herniation, because that's usually going to result in death if we don't do something about it. But here's, whatever the brain injury causes, like a dysregulation in there. And then we like to calculate our cerebral perfusion pressure based on our MAP minus our ICP. And I know what you're going to say, how do we know what the ICP is if we don't have an ICP monitor? And that's correct. So we kind of manage it, without knowing those, we tend to focus more on like our MAP and our blood pressure, and we try to prevent any of these like secondary insults, because the primary insult is going to be whatever the injury is. We can't do much about that or anything about that, so we try to manage all of those other complications with it, and we want to make sure we keep that cerebral perfusion pressure appropriate. But here's kind of our goal. So any sort of hypotension has like a significant morbidity and mortality rate associated with it. Even very short periods, like a minute or less, it's going to cause significant mortality increase in these patients. So it's important we focus on heavily on our like A, B, C, Ds, and make sure that we avoid any hypotension. So these ones typically we like a MAP like a MAP of 80 or greater for these patients, so that we make sure we maintain that cerebral perfusion pressure. What's a normal MAP?
Above 60.
Yeah, 65. So that's what we try to keep most patients at, is like 65 or above. And these ones we go a little higher, just like with like hypotension, you know, we consider what, 90 systolic or below. So for these patients, we like to keep them a little bit above that. So like at 110 is going to be where we like to keep our brain injury patients at. And there are, you know, you'll see different guidelines throughout practice. This is just what's in a textbook. Nowadays, we use like the what, you know, one of it, we call it the big criteria because it's brain injury guideline criteria. So they'll have different, and the Brain Trauma Foundation will have different metrics, like age plays a factor in this as well. So sometimes you'll see, you know, maybe depending on their age and comorbidities, we're looking at like maybe a 120 for certain populations, but you know, generally over 110 is what we kind of generalize for all trauma. But just something to be aware of, you'll see different, you know, numbers out there. So, you know, we like to look at it like primary brain injury versus secondary brain injury. The secondary injury is going to be what we can do something about. So, you know, they had some sort of trauma, so there's either, you know, a contusion, they've got, you know, a hematoma, bleeding, they got a subarachnoid, subdural, epidural. There's not a lot we can do about that other than prevent that secondary injury from hypoxia, hypotension, and all of the other metrics we're going to talk about. And this is what I was saying, don't confuse the secondary cascade with an insult. The secondary insult, you know, talks about certain conditions that will worsen that long-term outcome, so which is going to be our hypertension, hypoxia, you know, hyperglycemia, increased ICP, and that's what we're trying to avoid in our acute management of these patients. So here are some of the different herniation syndromes. This is a complicated slide. We'll dive into the more common ones from this that you may see, and you know, some of them are hard to differentiate from others, but you know, pay attention to the ones that we talk about and what differentiates them, because a lot of them will look the same on presentation, but pay attention which one has, you know, a blown pupil and contralateral weakness versus other findings that you may be able to differentiate them with. But at the end of the day, it's, you know, if you see any herniation signs, we do the same treatment to prevent that. But here are the ones we'll talk about, like our uncle is one of them that's easily differentiated by our physical exam findings. And our subfalcine is usually going to be the most common. And then we have other ones that, you know, have findings we can actually differentiate. And we're talking about testing, but really anywhere in there. So if you have like some sort of, you know, area for that brain to escape from, like, you know, a significant skull fracture or one involving any of your sutures, things like that, depressed fractures, that, you know, you run the risk of that brain trying to escape or come out of the brain at that area, leading to herniation, and no bueno, leads to death. But here's our uncle herniation, and this one's going to be, you know, the uncus of the temporal lobe gets displaced down through the tentorium, and it causes specific kind of symptoms or findings related to it. So you get compression of that cranial nerve 3, so you get a unilateral fixed dilated pupil. And then further herniation, you start to get that opposite or contralateral motor paralysis, and then they can start posturing at that point, cerebral posturing. Our subfalcine is going to be the most common. There's just going to be a midline shift, and that's always something we're paying attention to on our CT scans, is do we have any midline shift? And there's, you know, different people tell you that different deviations that are appropriate, like anything usually 5 or more, we start to consider, or we consider it a midline shift or a significant midline shift that we need to do something about. So we always want to pay attention to that. And this one is sometimes kind of hard to differentiate on exam from other ones, but, you know, common being common. If you've got, you know, contralateral leg weakness, usually you got to have, you know, some sort of imaging to try to in order to diagnose this. And then we got our cerebellotonsillar herniation. So you have those 2 tonsils on the cerebellum, and then you get herniation through the foramen magnum. And this one's going to have like pinpoint pupils, flaccid paralysis. This one usually has a very poor outcome. Then we have our upward transentorials. That one has conjugate downward gaze, so it's a little bit different than some of the other ones. So that's why they like to test on these things, and you'll sometimes see it on board questions. But for us in the emergency department, we manage them all the same. We need to find ways to decrease that intracranial pressure and prevent that herniation, which really, they need some sort of neurosurgery intervention. Is going to be the definitive treatment for all these. And then here's our GCS score. I know you guys have gone through it many times, but we have our eyes, verbal, and motor responses. It is important to know the GCS and have it memorized, although it'll usually be on the wall of the trauma room, and sometimes it can be confusing trying to calculate a GCS, so it seems straightforward, but like I had a weird patient on Sunday that the nurse is like, how do I count? What are you even going to calculate as GCS? And I'm like, I'm going 15, but the guy had like global amnesia, and so I was working him up for a stroke, but he actually had a diagnosed history of transient global amnesia, which apparently is a thing, which, I've heard of it, but never, and we sometimes will consider it, but our concern in the ER is some emergent condition that's got it. So we were looking some sort of, cerebrovascular accident, maybe some sort of intracranial hemorrhage and things like that, ischemia. But so the way the patient presented, and it's actually funny because we came to find out the most common precipitant for transient global amnesia after they're diagnosed is actually sexual intercourse. And it was like, I don't know, so it all started at noon. Like him and his wife went to church, and then he doesn't remember anything from there. Like he was like alert, oriented, but he knew his name, didn't know the month, but he just doesn't remember anything. He's like, I don't know, doesn't remember what he did the day before, anything before that. But he was acting appropriately, and that's why it was confusing for GCS. And she was like, well, what are you going to call it? I was like, it was 15 to me. I mean, he's awake, alert, oriented. He just doesn't remember anything else. So it was just an interesting case. Hadn't seen a lot of. And we worked him up for stroke. Everything was normal, and then I transferred him. Typically, it's transient, like the name says, and they normally don't have a diagnosis. So we've considered it in the emergency department before, but we're like, no, we got to let neurology deal with this. And so it lasts for like 24 hours or less usually, and everything returns to baseline. And the guy was like, every 10 minutes he would look at his wife and he'd go, happened after sex again, didn't it? And he just kept repeating it like every 10 minutes. Because that's how it happened the first time as well. It was like his third episode of it. Like he had one every 2 or 3 years. It was interesting to me because I don't normally see that. All right, so our CT scan is going to be our best test for diagnosing all these injuries. So CT without contrast is what we typically start with for our trauma patients, and we're looking for some sort of bleed in there, looking for a midline shift. We can also see any skull fractures on here, not with this view or window, because the skull just looks very bright on this. But we want to make sure we can, look at all of that different tissue. We see our different densities in there, so anything that, is abnormal, we usually light up on there, or it'll be a little bit darker depending on what it is. And then here's the pathology we're talking about. So hopefully a lot of it's a refresher for you guys. But the two common ones, like on the pants and board questions, are your epidural and your subdural, because those are the ones that look, a lot different on your CT imaging, your subarachnoid as well. But the two most common are your epidural and your subdural. That they're going to test on the board question. So if we remember our epidurals like that, looks like that lens shape on there. And then our subdural is more crescent shaped, and the other ones will present with some sort of bleeding or hematoma in the brain in there, or like the subarachnoid, you'll kind of see some of that diffuse bleeding or densities in those different areas. But, so, what we want to do is calculate that GCS. It does correlate with outcome. And probably the best correlation is the motor response. So that's going to be, that's probably going to give you your most effective tool on there for looking at like mortality and morbidity associated with it is the motor response. But it has been, very well studied, validated, you know, we're trying to come up with newer things, and they've studied all sorts of different tools to see if we can diagnose some sort of traumatic brain injury faster. They've tried like little pupillary machines, and we've had to test them, which was difficult in the emergency department, but it shoots like some light and it measures microsecond responses for the pupils to see if we can expedite it. There are newer blood tests out there that will that have been shown to be decent for diagnosing like a TBI, but it's not. I mean, they're not commonly used at most places yet, but they're working on it. But what's important for us is, you know, especially in the emergency department, like what is the mechanism of injury? And if we can get a history, that's great. So sometimes it can be helpful to know, like, what was the patient's baseline right after the injury? Did they have, you know, were they acting appropriately? Were they walking around the scene? And sometimes that can be helpful for, like, if we remember, like, our epidural has that lucid intervals, they're acting normally, and then they declined after that. But sometimes you'll see, like, especially questions, they were walking right after, and then they precipitously declined on their transporter once they arrived to the ER. Other things we want to know, like how, you know, if it was a fall, how far was it? Were they restrained in the vehicle? How bad, you know, how much damage in the vehicle? Typical, you know, questions we want to know for all of our trauma patients. Were they ejected? Any fatalities at the scene? And then, you know, if we can get a history, like are they on blood thinners? That's something important we want to know as well. And, you know, if we can, what was their, you know, neurological status before this? Because some people can already have deficits, comorbidities, things like that. Like I said, medical history, you know, anticoagulants are really important. I want to say like clopidogrel is a big one that, you know, has been implicated for bleeds and other traumatic brain injuries. Same with any sort of like your Xareltos or other anticoagulants we want to know. Alcohol intoxication is important because we want to know what like our baseline mental status is, and if they're intoxicated, that can confuse us a little bit. And we also have certain conditions that are very common with alcoholics, like subdural hematomas. We see a lot more in alcoholics and elderly because you get atrophy of that brain, and so there's a larger space or area for that bleed to present in. So our physical exam, we follow our primary and secondary survey. So start with our X, A, B, C, D, E's. We stabilize that patient, treat any other concomitant injuries they might have. And then we address that brain injury after that. But getting our initial GCS is very important. You know, if we can, we like to get a pre-intubation GCS so we can trend that or monitor them throughout their stay. So during our ABCs or our primary survey, we like to look at their pupillary response. So that's important. That's usually the person at the head of the bed is checking their airway and they're shining a light, checking the pupillary response, which can be difficult in like a bright room. So sometimes you may have to include, you know, put your hand or cover the eye to assess that response. But any sort of single fixed and dilated pupil or bilateral cavity, any blown pupils are more concerning for some sort of herniation or increased intracranial pressure. If they're pinpoint pupils, then we think about maybe some sort of, you know, toxidrome or opiate overdose with it. And then, you know, if we can get a decent like motor neurological exam, that's great. You know, our GCS is helpful for that. Any posturing we want to know about, because that can kind of help us identify what level of the brain that they may have that injury associated with. So we have our decorticate and decerebrate posturing. Let me see, I think we got pictures, everybody remembers. There's our decorticate versus our decerebrate posturing. And you'll hear everybody pronounce it all kinds of different ways, so I don't know what's correct. Decerebrate, decerebrate, who knows? Shooter's preference. All right. So we need to determine if we need a head CT or not. So, and you know, really, anybody that we've stabilized, they don't need to go directly to surgery for any, you know, exploratory laparotomy or any other concomitant injuries we have to deal with. Anybody we suspect they have a head injury, we're going to get a head CT on them. So we don't want to delay that, other than, you know, stabilizing their other conditions. And sometimes those conditions will take priority for the head injury, because if they have no blood in them, then the head injury doesn't matter if we don't have any fuel in the tank. Typically, we get a head CT, even for minor trauma for elderly, so anybody 65 and older, we'll typically get a head and a C-spine, non-con CT on those. Just because old people tend to fracture more and they tend to have atrophy of the brain and a higher chance of some sort of bleeding in there. But cervical fractures are very common, especially in an unconscious patient or a comatose patient. So, I mean, 8% is pretty high. That's why we scan, most people's head and at least C-spine. And depending on the mechanism and other findings, they'll typically get all, basically head down all the way to the pelvis for their CT scanning in the trauma room. All right. So pre-hospital treatment, the goal of the pre-hospital treatment is the same as kind of our treatment in the emergency department, other than we want definitive treatment, which is neurosurgery. It's going to be preventing all of that secondary injury. So they're going to stabilize and transport to a facility that has neurosurgical capabilities if they suspect, moderate or severe TBI. And they're going to manage airway, so they'll have a lower threshold to secure the airway. And then they want to avoid any sort of hypotension. We also, that must have been like a long time ago, but they apparently used to do like prophylactic hyperventilation, which is not something we do because it causes vasoconstriction and it can worsen their traumatic brain injury. However, sometimes it's a last-ditch effort if they have signs of herniation. But our PCO2, we want to keep the normal range 35 to 45. And then we manage their hypotension a little bit more aggressively in the pre-hospital phase if we have a brain injury. And here's our primary goals. We want to prevent that secondary injury, keep that cerebral perfusion pressure appropriate, and then we want to keep their oxygen level appropriate. But hypotension and hypoxia have, significant increase in mortality. If they have, any of that, any hypoxia, any hypotension for any amount of time, it's going to increase significantly their mortality. So we want to correct that by intubating. Later on in the hospital course, we want to aim for like euglycemia. And our goal, if they have a head injury, is going to prevent that increased ICP and herniation, which, simple maneuvers initially is just elevating the head of the bed to 30 degrees. And we'll talk about other things we can do along the way. But here's some of the stats. So, like I said, any decrease in these can lead to a significant increase in mortality, which is why we want to manage them aggressively. And then we want to continuously monitor them for any signs of herniation. So any changes in mental status, what's my pupillary response? Do I have any irregularities? Are they starting to get a neurological deficit? Are they posturing? And then if we have a CT, then we're going to look for any of those signs of herniation or midline shift or any of those hematomas or bleeds we might see on there. And then, I feel like I'm beating the dead horse here, but our early management and preventing all of that secondary injury is going to have the best impact on the outcome of these patients. So our goal is to prevent any of that so that we don't have any sort of cell death, neuronal cell death. But that's when it's going to lead to, if they survive, that they're going to have significant sequela from it. But most facilities are going to have some sort of jointly developed protocol for managing all of these, and that's why at a level 1 trauma center you have neurosurgery there, so they're usually going to be there immediately helping you manage this. All right. So first thing, we want to make sure they have that airway. So we need to look at whether they need to be intubated. What's their GCS, 8 or less? We're going to intubate. Is there something else that can cause, hypoxia, or is there tension physiology there? So we need to make sure we treat a pneumothorax. And if they have bleeding anywhere, we want to, try to occlude that or resuscitate them with blood or get them to surgery so we can fix that. And then we like to use more short-acting agents in these head injuries. Especially for our like our sedatives, we want something fast acting that we can turn on and off so we can get a repeat neurological exam. Same with our paralytics, so typically succinylcholine is gonna be our quickest on and off switch for that. So we'll try, if they don't have any contraindications, we'll usually manage them with those faster acting agents. Like I said at the beginning, avoid any like nasogastric tubes or anything in facial trauma or sinus basilar skull fracture, because we run the risk of putting one of those tubes into their brain. And once again, hypotension, so it leads to some sort of ischemia, it'll lead to low flow in the brain or ischemia, and that's gonna worsen that neurotoxic cascade. It's gonna create more edema in the brain, and it's gonna make it a lot more difficult to treat if we have any hypotension in these patients. So once again, systolic, over 110 or the MAP over 80. And then if they have signs of like increased ICP, we need to start treating that. We don't use the permissive hypotension in these patients. Normally we're worried about like blowing a clot out, especially in the pre-hospital side, but these ones we need to keep their blood pressure up a little bit more. Like hypotension in a trauma patient, even if they have a head injury, we're not going to associate it with the head injury. We're going to associate it with some sort of hemorrhage somewhere in the body. So typically you're not going to get that hypotension from a brain injury unless it's in a later stage and you start to get that Cushing's reflex. What's the Cushing response? You guys remember the? Yeah, hypertension, bradycardia, and irregular breathing, whatever irregular breathing means. All right, so what we start with initially, anybody with head injury, we're gonna raise the head of the bed. So typically 30 degrees is what we recommend for initial like preventive steps. And these are things you can do in the pre-hospital side. There are things you can do with a head injury, even in like an aid station or a roll one, which a lot of you guys will be at. So you may have to place some like blankets, other things like that to raise the head of the bed on. When you have like a rigid litter in your roll one aid station in the hospital, we have usually nice beds we can adjust to manage that appropriately. But it does do a pretty decent job at decreasing that mean pressure, so like 10 to 15 millimeters of mercury, which is pretty good. And then any sort of hyperglycemia is going to worsen the outcome in these patients, so we like to maintain tight control in any moderate or severe TBI. So usually we say that's like 100 to 180 blood glucose. Sometimes we'll let it go a little higher, because if we start managing them within normally anything like 200, even like 250, you start giving insulin, you're going to run the risk of causing hypoglycemia at that point. So these patients, we run it a little bit lower in the normal range, and we may just have to give them some dextrose on top of it, or dextrose-containing fluid like D5, D50, whatever we need to keep them in that normal range without bottoming them down. And then if they have a fever, we would give them some antipyretic. Seizure prophylaxis is something we always want to consider, especially in our moderate and severe traumatic brain injury, because any sort of seizure activity can worsen the outcome. So the common one we use is going to be our levetiracetam. Since nobody knows how to pronounce it, we usually just say Keppra, or we use the brand name for it, but that's going to be our most commonly used seizure prophylaxis medication for these patients. And so all of these, we're getting on board and managing these, prior to any neurosurgical intervention. And then we do our typical labs, our trauma labs for all of these patients. And then here's signs of increased ICP. So, if they're still maintained appropriately, they'll complain of a severe worsening headache, might start to have vision changes, numbness, any sort of like focal or unilateral weakness in any of their extremities can be a sign. Seizures, they might start to become lethargic, nausea, vomiting. Those are things we need to monitor for, and if we see them, then we might need to increase our treatment to prevent herniation and get them immediately to neurosurgery. So big ones to look out for, any sort of blown pupil, so unilateral, bilateral pupillary dilation. So that's why usually every 5 minutes we're reassessing their GCS and their neurologic status, any hemiparesis. They start to posture, that's a bad sign. And then any other neurologic deterioration, we need to consider herniation at that point, we can manage them a little bit more aggressively. But we typically do GCS every 5 minutes, check their pupillary response until we get definitive treatment for these patients. And here, you know, other than elevating head to bed, there are other agents we can use. So the two most common are going to be mannitol and our hypertonic saline. Right now, you know, saline is becoming more favorable because mannitol is an osmotic agent. And they can have other side effects with it. So because of the profile, you know, we still use both of them, but hypertonic saline is more favorable nowadays. And, you know, I know you guys talk about fluids and fluid management in surgery. And it really, like, they do studies all the time on whether normal saline is better than lactated ringers, and they study it for everything. And really, at the end of the day, we're like, yeah, probably not a difference between anything, except, you know, the latest research, the latest data shows that normal saline is actually better for brain injury. So that's the only benefit, you know, only time that it really benefits using LR versus normal saline. Typically, you can get away with LR for everything, except there's LR shortages all the time. You know, sometimes we may have to use normal saline. But for brain injury, we prefer the normal saline. And then our hypertonic saline, so this is preferred. Like I said, this has become more in favor. So we want to use it for any, you know, sign, you know, it works great for hypotension, but it also any signs of increased intracranial pressure or herniation, we're going to start using our hypertonic saline. And commonly we have 3% normal saline. And we'll just give boluses, so we don't want to overdo it. So we usually start with like, sometimes we start with even 100 to 200 milliliter boluses, but usually 250 over 30 minutes is what we start with. We also have other agents that are like 20% and even higher hypertonic saline, but this is a common one that we'll start with if we have any signs of increased ICP. And then, what's a normal ICP? So, abnormal is anything over 20 is what we consider. Normal is probably around 10. But anything over 20 is when we start to worry about herniation and increased morbidity and mortality. So we need to get neurosurgery on board immediately, which if I actually know the intracranial pressure, they're probably on board already because they put a monitor in them for me to figure that out. And they'll talk about the different monitors and surgery, or you guys will talk about it in surgery, I think on your next block. But yeah, there's just different, you know, different ways they can monitor the CSF, from like intracranial bolts to other ones like ventriculo-septal monitors. And there are certain ones we can actually draw fluid off and decrease that ICP if we need to. But it's going to be a neurosurgical intervention performing all this. So we'll go into specific head injuries. I think it's a good time for a break. So everybody take a 10-minute break, back to 8:50. I gotta use the bathroom.
Now I'm gonna run in your ass and then I have so disgusting. You're gonna have to play Well, she had that heart surgery. It looked weird. Had to figure her share of your physical portion. That was clear. So, like, when I was looking at it, there's things that you know how we look at what's extremely abnormal and what's normal? This is like where I'm like, he looks they got one more test, then it says prolonged, but it was like not prolonged, like
Yeah, that's an appointment. Go, go! Don't try That's the only.
I think it just works.
Nobody wants to put their name on it.
Yeah, solar.
That's what it
Yep.
This thing is it's fine, but it's
Do they require a copy?
Yep.
LES. Or just like postcard.
All right, let's keep going. Yeah. All right, we're gonna keep going. So, we'll talk about specific brain injuries or head injuries. So, and really anything that can risk some sort of bleed in there. So, like skull fractures, a lot of times they're benign. We might have just small linear skull fractures and aren't depressed. But anything that crosses any sort of structures in there, like arteries, any major venous sinuses, or sutures, can have higher risk of brain injury with them. So, open and depressed fractures are gonna be more concerning. If there's any air or concern for air in there, we wanna treat them with some sort of antibiotics because we don't want any of that bacteria in there, especially getting into the brain. That can cause, significant morbidity and mortality associated with it. Any like depressed fractures that are greater than thickness of the skull, we need to, usually requires operative repair, so we need to consult with our neurosurgery folks. Basilar skull fractures run the risk of, CSF leaks. So, we want to consider those to be like a significant injury. And we worry about CSF leaking from somewhere. Sometimes, you might see it coming out of the nasal passage, or you may see it coming out of the ear. So they could have some any autourea associated with this. We need to be more concerned that maybe there's some sort of CSF leak. And they say you can stick, some gauze there, and there might be pink outline around it. Which, yeah, whatever. If we have any concern for it, we're going to consider it CSF and consult our neurosurgeon. But sorry, I got error messages popping up on here. So that dural tearing can lead to that autourea or the rhinorrhea. And then other concerns are at the base of the skull. If it's cribriform plate, we worry about being able to pass that NG tube through going into the brain. Used to have a good picture on here. Maybe it was in the surgery slide. There's a good picture of an NG tube in the brain, which is usually poor form, but it can happen. And then here's what we see on exam. So you might have that maxilloid ecchymosis or periorbital ecchymosis. And then we always want to look in the ears. So normally when we run a trauma, the person at the head of the bed who's running the airway, after they secure the airway, they're checking pupillary response, and they're also doing an otoscopic exam to look for any hemotympanum. But patients may complain of vertigo, they might complain of deafness or hearing loss with it. And then because of all of our nerves that run through there, you can have a cranial nerve 7 palsy as well, so facial palsy. All right. I've actually had quite a few patients that show up with no head injury and they think they have CSF leaking from their nose. It's kind of odd, but something I've seen not infrequently randomly. People show up, I think this is CSF, and they take a picture, bring it in. I'm like, I don't know, I'll scan you. All right, so any CSF leaks have a higher risk of meningitis, so runs risk of getting some sort of bacteria in there, so we need to treat them with antibiotics, or so we'll start, empiric antibiotics on these patients. And we need to consult neurosurgery immediately. We also, want to make sure we're using our brain injury precautions, so elevating the head of the bed, and then the neurosurgical team might place some sort of drain in there. Now we'll move on to our more common findings for traumatic brain injury, bleeding. So subarachnoid hemorrhage is going to be, a common one that we see. And then it'll look like, you can get that blood in the CSF, so sometimes we have to do a lumbar puncture with it, but they complain of what we typically associate, that severe headache, photophobia. They might have meningeal signs. It can be confusing, especially if they don't have head injury associated with it, but we're talking about trauma today, so typically we're not thinking of meningitis, especially if it's acutely presenting. And then if we can get that CT scan within the first 6 to 8 hours, it's usually appropriate to rule out a subarachnoid hemorrhage. However, if they show up after that, we may have to do a lumbar puncture and evaluate the CSF for any sort of blood in there, xanthochromia. And that's what it looks like on after your lumbar puncture. You usually draw 4 tubes of fluid, and hopefully they're not all bloody because you didn't do a traumatic tap. But it does happen. And then we're looking for that xanthochromia. So hopefully we can see it on there, or else we have to send it down for sampling. And then here's our more common, well, there are probably less common than ones, but these are ones we can differentiate on our exams and our CT scans. So these are commonly asked board questions on the pants. I'm sure I ask a bunch on your guys' test for this block. But our epidural, it's important to know, it is like bleeding from that middle meningeal artery. That is a common question, like pathophys, that's on your board question. So middle meningeal artery disruption. And this one can present with that lucid interval. So they had some sort of trauma. They were walking around on scene after the motor vehicle accident or whatever it was, and then they declined and they became unresponsive. So that's commonly how you see it, or how they ask it on a board question. Whether it happens in real life or not, who knows? Like it says it's less than 30%. This one can be more significant bleeding because it's arterial, so it's a higher pressure versus like your subdural, which is going to be more venous bleeding and slower. So this one, we worry about herniation, or can lead to herniation relatively quickly after the injury. So, our epidurals we manage with our brain injury, like prophylactic treatment, elevate the head of the bed. Any signs of herniation, then we need to, start hypertonic saline, get neurosurgery on board immediately. If we can evacuate the hematoma, usually a pretty good outcome if it's not delayed. And then here's what it looks like. So we have that, lens shape or convex shape in a focal location. It's classic for your epidural hematoma, so it's important to recognize it on your CT scans and imaging. Next we have our subdural. So this is tearing into those bridging dural veins. And it's a little bit slower bleeding. It's more common than an epidural, especially in like our elderly and alcoholics, or anybody with like brain atrophy or more space around that area. And these ones we classify as acute, usually in the first 48 hours versus subacute. That's like 48 hours to 2 weeks. Now we have over 2 weeks. And that will be like common presentations with it. So especially in our elderly alcoholics, they may not present initially. And then they'll get some sort of neurologic deficit or finding a few days later. I think my dad did it. He hit his head on a cabinet, didn't think anything about it, and then 2 days later he like drives off the road and crashes his car. And he had a subdural from a couple days before. He was fine. He was good. He's already kind of crazy, so we were like, whatever. It seems to be pretty normal for him. But, these ones may not have your CT findings like you initially see with hemorrhage. So you got to, evaluate that CT a little more when it's like the subacute versus chronic. After 2 weeks is when we consider it chronic. Most of these patients are still going to get some sort of neurosurgical or surgery intervention, sometimes depending on how long it's been there. And the patient's neurologic status, it may be something they manage in the hospital without surgery, but most are going to end up with surgery. And it can be difficult because sometimes patients don't recall what happened. So that's why it's important to kind of categorize them into those populations and risk factors. So elderly, alcoholics. So you normally have that like crescent-shaped finding on CT scan. The subacutes are going to look less dense on their isodens because you've already had that iron. The iron in the blood has already like reabsorbed, so you may not see it on CT, or it may not be as bright. So sometimes we may have to get an MRI or further imaging on these patients. And here's what our acute looks like. So that kind of crescent shaped in there. It's crossing suture lines and things like that. So classic for our subdural. And here's what it looks like for more of a chronic subdural. So you can see it is like hypodense in that area, but it doesn't light up like it normally would with an acute bleed inside their acute hematoma. So, on our end, we're gonna, consult neurosurgery for all of these, and they're gonna decide what sort of intervention they need. But, a lot of it's gonna be based on what's their initial GCS, do they have any neurologic deficits with it, and then what's their risk for surgery as well. But either way, we're consulting neurosurgery, and they're gonna determine what we need to do for these patients. But acute subdurals are typically gonna get neurosurgical intervention immediately. They have a higher rebleeding rate for chronics as well, so that's why most of them get some sort of neurosurgical intervention. Here's a great chart to kind of differentiate or common or classic symptoms you might see with this. So like I said, epidural, you want to think about that lucid interval, and then they deteriorate afterwards. Always remember that it's that middle meningeal artery. Subdural is going to be, tearing those bridging veins, and they may or may not present like acutely or with rapid loss of consciousness, and usually don't have lucid interval, especially on like board questions, or else how would you differentiate it without a CT scan, right? And our subarachnoid, this is gonna, this is really anybody depending on the mechanism of injury, but more commonly seen with like a moderate and severe traumatic brain injury. And then we have like our different contusions, which we only really can differentiate based on our CT scans. Diffuse axonal injury, so this is, shearing forces, probably one of the more common findings we see on CT scan. However, sometimes you can't even see it on CT scan because they need the MRI. We've seen a lot with like blunt trauma, so like that contra coup injuries where, your acceleration followed by deceleration, your brain kind of moves around in there and it causes those shearing forces and diffuse axonal injury on the brains. These ones are often irreversible, so not the best outcome, but you'll see on imaging they have these like little punctate hemorrhages on there, and you'll see, small differentiation between the gray and white matter. You kind of lose that normal differentiation you have, and that's consistent with that diffuse axonal injury. All right, so, considerations is going to be like our concussion. So this is going to be the most common thing you're going to see are these mild TBIs and concussions. And the question is, what do we do for them? Do they need to stay in the hospital? Do they need to go home? Technically, if it's mild, their GCS should be 13 to 15. I think most guidelines now, anything under 14, we should probably keep in the hospital for further management. And anything mild, so 14 to 15, no neurologic deficits, they have good follow-up. These are patients we can send home with just good follow-up with their primary care provider or somebody who can manage them. And then we usually want some sort of return to play guidelines, so we don't want them immediately going back into sports and getting another impact, because that could be make it significantly worse if they have multiple, TBIs following their first one or multiple concussions. And most protocols recommend brain rest. There's always new research. How long should the brain rest be? And it's usually starts to become less and less. So just pay attention to whatever the current guidelines are for concussions and return to play or return to sports criteria. Because most commonly you'll see other sporting injuries like football, soccer, things like that. Other special considerations. Anybody on anticoagulants? So are they taking any anticoagulant like Xarelto? Are they on warfarin? Are they on aspirin? Clopidogrel is a commonly implicated one. So these patients may show up with a normal CT scan, and these are ones we have to have a higher suspicion. So instead of sending them home with even if it's a milder TBI, a lot of times we'll keep them in the hospital and monitor them because they have a higher risk of bleeding or delayed bleeding in the brain. So our disposition, I kind of said it earlier, anything mild, no neurologic deficits, we can usually send them home, so GCS like 14 to 15. Anything below that, we admit them to the hospital for either serial exams, a neurosurgery consultation. And you'll actually have guidelines and criteria. Like I said, there's these big guidelines, so the question is, how do we manage them? And you'll get we get a lot of kickback from neurosurgery, like, why are you calling me? They're like a big criteria, whatever, blah, blah, blah. So you'll just go with whatever your local protocol is for anybody you want to admit or that is greater than a mild TBI. All right, let's do a check on learning here. All right, EMS brought a 19-year-old male after an altercation at a bar. He has shallow respirations, is moaning, opens his eyes to painful stimuli, he has abnormal flexion towards the body, Significant bruising along his mastoids under his eyes, which the following is most appropriate next step to managing this patient. What do we think? Intubate him, right? Let's intubate this patient. Good. So maybe, does have findings maybe consistent with basilar skull fracture. However, he was in an altercation, so sometimes it can be hard to tell. But we don't have any facial, any sort of intraoral trauma or any contraindication, so we're gonna, perform endotracheal intubation on this patient. And we maintain C-spine stabilization. All right, 24-year-old male, significant head trauma after motorcycle accident, demonstrates papilledema on physical exam, as well as his optic nerve sheath diameter is increased on the bedside ultrasound, which we'll teach you guys how to do that during our next block. Neurosuscitated with 2 units of blood, remains hypotensive, current vital signs are 88/60, heart rate 124, respiratory 18, and SpO2 98% on a ventilator, which will fund interventions in this next step in managing this patient. What do we think on this one? You think this one can be kind of tricky, right? So the question for this one is, he's gotten 2 units of blood, still hypotensive. Vital signs are still kind of abnormal. If we didn't have any other signs of hemorrhage on there or suspect any other hemorrhage, possibly we could look at hypertonic saline for this patient. I mean, you can't go wrong with administering more blood products on this, so you haven't seen a response with the first 2 units, so it would make you think what else could be causing this hypotension. But I think in this patient, without any other signs of bleeding, we probably want to get hypertonic saline on board immediately. But technically, D still isn't wrong. So he does have the papilledema or signs of increase in the cranial pressure, so that makes you more suspicious for some sort of brain injury. But once again, it's a motorcycle accident, so probably polytrauma. I never changed this question because I like it, because there's 2 right answers, but which one's going to be more right? Which one's more right? That's where it gets in the weeds, and that's how it is on your guys' pants. There's always 2 right answers. One of them's more right than the other, so it's a little bit harder than what we do here, because we get a lot of people arguing with us. Well, you can't argue with the pants. They're just like, yep, you failed. Try again. Something to always think about. You should have 2 right answers. One's more right than the other. All right. 34-year-old male presents to the ED following a severe head injury during a motor vehicle accident. He's got right-sided pupillary dilation, ptosis, altered level of consciousness, left-sided motor paralysis. Which herniation syndrome are we talking about? What do we think? Yeah, uncle herniation. If you're unsure on one, it's not the most common, but if you're unsure on a test, I would just go with uncle herniation, because that's the easiest one that you can test on a board question. Now, subthalcine is going to be more common, but really the findings are difficult to differentiate from the other herniations on there. So, uncle herniation. All right, what questions y'all got? Tomorrow, I'll finish the lectures. It'll be, I think, spinal trauma, and then I'll do a review afterwards. And then your class leader has the instructions for Thursday. You guys can fight amongst each other which one you want to go to. But it'll be half days in a lab, but we're going to practice it. My recommendation, and I know you guys are studying surgery and are worried for that, I'd look through some of the procedures on there, or refresh on our interventions for intubation, our invasive versus non-invasive measures. We're going to practice all those at the lab. So it'll be nice if you know how they work, but if not, we'll explain it to you there. All right, I'll hang around if anybody has any questions. Y'all have a good